There's a lot of merit in letting your next word be your breath. Now, I'm not a big self-help guru guy, but there's this guy, Jefferson Fisher. He has a podcast, he has whatever. But he has a quote, and he says, sometimes just let your next word be your breath. And I think that rings true in a lot of medicine, where if you're a nurse or a provider or a doc or whatever, and people kind of trauma dump on you, you have that inkling, and I think it comes from a good place, to say the right thing, just to have the perfect answer, whatever. But oftentimes, just having your first word be, and to kind of take that 5 seconds of slowing the momentum down does a lot of good. Because I've definitely felt the other side of this, right? Like a patient comes and they have cancer and someone passed away in their family and they were in a car accident, they lost their job, and you want to be like, all right, well, everything's going to be okay and we got what's going on. The patient, rightfully so, will be like, no, you don't. You're not going to be able to solve all my issues here. And sometimes I think it's therapeutic for the patient to see you take in the gravity of their situation and not just immediately blurt out like a 2-second clip as if it's going to solve all of their issues. So in cases like that, right, like where a patient comes and they throw the kitchen sink at you in terms of trauma, take a breath, and I go, well, I have a couple thoughts on what we could do today. Let me know what you think. Because oftentimes it's not everything the patient says. Sometimes it is. But sometimes if it's in a heart failure and I had a stroke and this and I got a divorce and whatever, the thing that brought them was, I have stage 4 cancer, I have breakthrough pain today, I can't keep anything down, I keep vomiting. Can we focus on that for a minute? And I'll usually say that back to them. I'll be like, you have 15 things going on. But the thing that's sticking in my mind is this last thing. Am I right in assuming that that's the thing that we're going to focus on today? Because I'll be wrong sometimes. My impression on what I think is most important to them can be wrong sometimes. And they'll say, oh no, I'm not worried about X. I'm worried about, am I having a stroke or am I just dizzy? I feel like you can do a lot of harm continuing that diagnostic momentum. All right, well, we're going to get a scan, an MRI, and we're going to, whatever. When that's not even why the patient's there.